Welcome, everyone. My name is Ryan Dutcher, and thanks for joining us today. We're excited to walk you through one of the most significant privacy shifts healthcare teams will face this year, the 2026 alignment of 42 CFR Part 2 with HIPAA. Today's session is designed for small to mid-sized healthcare organizations and is available to you free of charge. North Country Communications is a healthcare communications and compliance consultancy focused on helping these small organizations navigate high-stakes regulatory changes with clarity and confidence. We specialize in HIPAA compliance, breach response, crisis communications, and operational readiness, always with an emphasis on plain language guidance and practical implementation. Our work spans provider organizations, health systems, behavioral health programs, and digital health companies. We help teams translate complex rules into workflows that actually work in real clinical and administrative environments. Today's session is part of our ongoing effort to support healthcare teams as they prepare for the 2026 alignment of 42 CFR Part 2 with HIPAA, one of the most significant privacy shifts in years. I'm joined by Rachel Seeger, founder of North Country Communications. Rachel specializes in healthcare communications, crisis response, and compliance strategy. She's been helping organizations prepare for this rule and develop solutions so covered entities are ready on and after February 16th, 2026, the date full enforcement of the 2024 final rule, which aligns 42 CFR Part 2 with HIPAA, begins. Now, Rachel, take it away.
Thanks, Brian. As Brian mentioned, and as many of you are aware, the U.S. Department of Health and Human Services, HHS, has implemented new enforcement and regulatory requirements that protect the confidentiality of substance use disorder patient records. We call that SUD. This program marks the first time the department will use civil enforcement to protect the confidentiality of SUD patient records that are covered by SUD programs. The new program executes the SUD confidentiality provisions of Section 3221 of the Coronavirus Aid, Relief, Economic Security Act, or CARES, and its implementing regulation at 42 CFR Part 2. We call this Part 2. Beginning February 16, 2026, entities and persons subject to the regulation protecting the confidentiality of SUD patient records must comply with all applicable requirements. The penalties for non-compliance align with the penalties available under the HIPAA privacy, security, and breach notification rules, so these can be significant. The HHS Office for Civil Rights, or OCR, is open for business on Part 2 and will begin conducting investigations under this new program that may be resolved through a range of civil enforcement mechanisms. And these can include entering into resolution agreements, securing monetary settlements, obtaining commitments for corrective action, or imposing civil money penalties for the failure to comply. A quick word about who is covered. In addition to Part 2 programs, this alignment now extends to HIPAA-covered entities, their business associates, including employer group health plans, clinics, hospitals, primary care groups, and dedicated SED treatment facilities.
OCR has begun accepting complaints alleging violations of the regulation that protects the confidentiality of SUD patient records, and has a process in place for notification of breaches of SUD patient records. OCR has also developed a model patient notice and updated its model HIPAA notices of privacy practices for regulated entities to use in providing notice to patients on how federal law protects the confidentiality of SUD patient records. Today's session is intentionally practical. In addition to the overview of the rule and its requirements, we'll translate the final rule into operational steps your teams can actually implement. By the end, you'll know exactly what needs to change in your workflows, notices, consent processes, and legal response pathways. Now let's move on to the next slide, slide 3, 42 CFR Part 2, or the Part 2 rule. Part two is about protecting patients seeking treatment for substance use disorders from stigma, discrimination, or legal consequences. Historically, these protections were more stringent than HIPAA, often causing operational friction in integrated care settings. Patients' records could not be shared except under very limited consent-based circumstances. The final rule seeks to preserve confidentiality while reducing barriers to treatment, payment, and healthcare operations, or the acronym TPO.
It was really a shield. It was written to make sure that someone could walk into a rehab clinic or talk to a counselor without worrying that it would follow them back to their employer into the courtroom. The rule covers SUD records originating from a federally assisted program, which could include hospitals, clinics, or even certain telehealth providers receiving federal funds. It dictates when and how these records can be disclosed and to whom, based on the patient's consent. Unlike HIPAA, which allows many uses for TPO, Part 2 restricted disclosures almost entirely unless the patient signed a specific authorization. Until now, even if the patient signed a release, that consent was usually limited to one specific purpose. If another provider needed records later, a new consent was required. That's how strict Part 2 was. The biggest operational challenge under the old rule was the fragmentation of care. For example, a primary care doctor might not know when a patient was receiving SUD treatment because the SUD program couldn't share information without a fresh consent each time. These silos could result in clinical blind spots, especially dangerous when managing medications or mental health comorbidities. The new 2024 final rule seeks to address this by allowing a single consent that enables ongoing sharing of under HIPAA's framework once the record enters the HIPAA environment. Even as these changes align Part 2 closer to HIPAA, the core privacy promise isn't weakened. The patient continues to hold the authority over non-TPO disclosures, such as to employers, family members, or law enforcement. The rule still prohibits the use of SUD records to investigate or to prosecute the patient for a crime. Think of this as privacy re-engineered, not privacy reduced. The point is to make care safer to share, not easier to exploit. Clinicians get the information they need, but patients still get the protection that they deserve. Healthcare providers and their staff need to understand that these are not just legal concepts. They affect daily documentation and communication. How records are tagged, labeled, or shared in the electronic health record, or EHR, matters. Likewise, a simple note about past SUD treatment may bring Part 2 obligations along with it. When organizations make HIPAA and Part 2 data, mix HIPAA and Part 2 data, everyone involved must know when they're working with protected content and what limits apply.
So when we talk about Part 2 alignment, it's not just compliance, it's trust. Patients are more likely to seek help when they know we handle their information responsibly, and care teams are more effective when the information flows safely. Now, let's move on to the next slide, slide 4, the CARES Act of 2020. The Coronavirus Aid, Relief, and Economic Security Act, also known as the CARES Act, is a $2.2 trillion economic stimulus bill passed by the 116th United States Congress and signed into law on March 27, 2020, in response to the economic fallout of the COVID pandemic in the United States. While most people associate the CARES Act with COVID relief, it also included a major and often overlooked provision for behavioral health privacy modernization. Lawmakers recognize that Isolation of SUD data under older Part 2 rules was hurting care coordination, so the legislation adopted key changes. One component of the CARES Act recognized that the strict isolation of SUD records was limiting whole person care. It pushed for alignment with HIPAA's privacy rule while maintaining essential privacy protections. It also introduced civil and criminal penalties, breach notification, and expanded patient rights similar to those under the HITECH Act, an Obama era economic stimulus package that encouraged adoption of the electronic health record, or under the acronym EHR.
Or CARES, a patient's substance use records were so tightly protected that even their primary care team, pharmacy, or hospital might not know the full picture. The fragmentation often resulted in medication conflicts, duplicate services, and safety risks. So while the world was focused on COVID, Congress was also focusing on the opioid crisis. They worked to modernize the legal infrastructure that protects people with substance use disorders, knowing that mental and behavioral health are integrated into public health. The CARES Act amended 42 USC, US Code, Section 290 DD2. That's a mouthful there. It's a statute governing Part 2 to align it more closely with HIPAA. It authorized HHS, specifically the Office for Civil Rights, or OCR, and the Substance Abuse and Mental Health Services Administration, or SAMHSA, to revise Part 2 regulations so that disclosures for TPO could occur under a single consent once SUD records enter a HIPAA-covered setting. They could be shared for TPO the same way other medical information is. And it also formally extended HIPAA-like patient rights to individuals receiving SUD care. This includes the right to access the records, the right to request amendments, and the right to an accounting for disclosures. This began the journey that we're now completing with the 2024 final rule, with enforcement beginning February 16, 2026. In short, CARES gave SAMHSA and OCR the green light to take Part 2 out of the 1970s and build it into our modern interoperability framework. Critically, CARES Act didn't eliminate confidentiality. It preserved and clarified where patient protection must remain absolute. And it specifically reaffirmed that SUD records can't be used in legal proceedings, criminal or civil, without a court order or explicit patient consent. The Act also extended criminal and civil penalties for unauthorized disclosures to make them consistent with HIPAA enforcement mechanisms. This was a major statement from Congress. Privacy violations in behavioral health are not minor offenses. They carry the same weight as any other protected health information PHI breach. The message from Congress was clear that treating a person's recovery journey as private healthcare information isn't optional, it's mandatory. And before CARES, if a Part 2 program experienced a data leak or unauthorized release of information, the rules for reporting were vague. The CARES Act aligned Part 2 with HIPAA's breach notification rule, requiring notification to affected individuals, reporting to the Office for Civil Rights. In cases affecting 500 or more individuals, reporting notification to the media, and documentation of response efforts. This is pivotal because it ensures transparency and accountability for behavioral health data at the same level as all other health information. From this point forward, substance use treatment data has to be managed like any other patient data, securely, transparently, and with the exception of full accountability when expectation of full accountability when something goes wrong. The CARES Act is a starting line for a two-step process. Step one, legislative authority and direction back in 2020, the CARES Act, and step two, regulatory implementation culminating in the 2024 final rule. It gave healthcare organizations a roadmap to merge compliance frameworks, no more managing HIPAA and Part 2 in completely separate silos. And at the same time, it elevated behavioral health privacy to a visible compliance priority equal to any other part of patient care.
Yeah, and think of the CARES Act as an architectural blueprint. It didn't rebuild the house yet, but it laid out the foundations and the floor plan. The final rule of 2024 is the construction work that turns that plan into reality. Now let's move on to slide 5, major changes in the 2024 final rule. Single patient consent. This is perhaps the biggest shift. One-time consent now covers future TPO disclosures to HIPAA-covered entities. Once the patient consents, these entities can share information like any other HIPAA data. No repeated consent is required. Redisclosure. Once under HIPAA, the info can be shared per normal HIPAA rules, a major simplification for the integrated care teams. Notice of privacy practices, NPP. Part 2 programs must now issue an updated HIPAA-compliant notice of privacy practice explaining uses and disclosures clearly to patients. This is where the rule really changes how we operate day to day. These 3 changes reshape how consent, redisclosure, and privacy communication will work in every organization that handles substance use disorder data.
That's right, Ryan. Single patient consent is really a paradigm shift. Part 2 required consent for every disclosure previously, even between clinicians treating the same patient. Now, patients can give one comprehensive consent that covers all TPO functions across the HIPAA ecosystem. Think of it as TPO consent. Once signed, that consent allows ongoing communication between SUD providers, primary care, specialists, payers, and care coordination teams. The key here is trust through clarity. Patients still control the initial release, but care teams no longer need to chase repetitive signatures. This change supports integrated, value-based care and reduces operational bottlenecks. This single consent model isn't about loosening privacy, it's ensuring that the right people get the right information at the right time and treat the whole person.
Let's move on to slide 6, alignment with HIPAA. Definitions. Bringing terms like business associate and healthcare operations into harmony reduces confusion and legal risk. Patient rights. Individuals can now request access, amendments, and accounting of disclosures, mirroring HIPAA rights. Breach notifications. Use the same process and timelines as under HIPAA if Part 2 records are breached. Penalties. Enforcement aligns with HIPAA, handled by OCR, with similar civil and criminal frameworks. This harmonization means integrated compliance programs can manage both HIPAA and Part 2 under a single structure.
In plain terms, alignment with HIPAA means we're no longer managing privacy in 2 different worlds, one HIPAA and one Part 2. This harmonization makes it easier for providers, clearer for patients, and stronger for compliance.
Let's move on to the next slide, slide 7, continued protections under Part 2. The final rule does not weaken confidentiality, it strengthens trust while enabling better care. Records still cannot be used against patients in criminal, civil, or administrative proceedings without specific authorization or court order. Public health and research disclosures remain permissible, consistent with existing privacy frameworks. Any disclosure beyond TPO, such as to employers or law enforcement, must still have explicit patient consent.
In short, modernization does not mean dilution. The same walls of trust that protect patients remain firmly in place. HHS has just built clearer walls for care coordination inside them.
Let's move on to the next slide, slide 8, recommended steps for organizations. Update consent forms to reflect single consent structure and redisclosure rules. Align privacy policies across HIPAA and Part 2 to eliminate conflicts. Train staff, emphasize redisclosure, breach reporting, and patient rights. Revise notice of privacy practice to include Part 2 language. Review business associate agreements, or BAAs. Ensure Part 2 handling clauses are included. Identify and label Part 2 records to apply appropriate handling protections.
The 2024 final rule gave organizations nearly 2 years before enforcement began in February 2026. That safe harbor window is now closed. With that said, achieving compliance isn't just a paperwork exercise. It's a multi-layered change involving policy, technology, and human behavior. Compliance isn't something you can fix overnight. It has to be built, tested, and lived by everyone long after the enforcement deadline has come and gone. Why? Legal exposure, criminal and civil penalties will mirror HIPAA now. Waiting too long increases the risk of unintentional violations. Operational readiness. Updating consent forms, policies, and EHR templates takes time and cross-department coordination. Training. Staff need not just new forms, but new instincts, when to share, when to pause, and how to flag Part 2 data in workflows. Trust and reputation. Demonstrating proactive compliance strengthens patient confidence and community credibility. This isn't the only regulatory obligation. It's part of a broader quality and safety initiative. Aligning Part 2 with HIPAA gives organizations the opportunity to streamline their privacy architecture and reduce redundancy. Smart organizations are viewing this opportunity not just as compliance, but as modernization, an investment in safer, cleaner data workflows that support whole person care.
And the rule is final, the expectations are clear, and the timeline is fixed. Work ahead is about building confidence for regulators, for care partners, and most importantly, for patients trusting us with their data. Let's move on to the next slide, slide 9, identifying Part 2 records in your environment. Many organizations underestimate where Part 2 protected data lives. It's not limited to treatment notes, can include billing, referrals, care coordination, or even legal correspondence mentioning SUD, substance use disorder. Federally assisted programs automatically fall under Part 2, but data may spread through electronic health records or shared documentation systems. We encourage you to conduct a data inventory. Identify all systems, files, and workflows where Part 2 data may exist.
Think of this data inventory along the same lines as your risk analysis that you've adopted to comply with the HIPAA security rule. One of the first steps towards readiness with Part 2 alignment should be a documented map of where Part 2 data may exist. While Part 2 clearly applies to federally assisted SUD programs, the reality is that protected data often spreads far wider. Within EHRs, across departments, in care coordination notes, billing files, or even referral documentation, inside legal correspondence, emails, or case management systems. If your organization touches SUD information in any form, even once, these privacy protections can travel with the data wherever it goes. Identifying these records isn't an IT exercise, it's really risk visibility. You can't protect or appropriately share something if you don't know it's there. A structured inventory helps answer key questions. Which systems contain Part 2 data? Who can access it? How is it blocked? How is it labeled, stored, and transmitted? The goal is to make Part 2 data traceable and intentionally managed, not accidentally overlooked. We're going to talk about a real-world scenario, the oral surgeon and the care coordination note. Let's take a simple, everyday example. A primary care provider sends an oral surgeon a brief care coordination note when referring a patient for a dental procedure to address an infection. The note includes a medication history and mentions that the patient recently completed MAT, or medication-assisted treatment. MAT is a comprehensive approach to treating substance use disorders by combining FDA-approved medications with behavioral therapy to reduce cravings, manage withdrawal, and support long-term recovery. The surgeon now has Part 2 protected information in their possession, even though they're not part of a former SUD program. That note effectively carries Part 2 confidentiality obligations into a new setting. If the oral surgeon then uploads that document into their practice's EHR or shares it with another dentist or an anesthesiologist, they need to understand whether the redisclosure is permitted under HIPAA and now under the newly aligned rules, how the patient's consent applies or limits further sharing, how that record is labeled or restricted in their system moving forward. And this is how Part 2 data propagates across care settings, not because of bad intent, but because clinical communication is so important and fluid.
Yeah, and scenarios like these show why it's critical to train all healthcare providers and their staff, not just SUD specialists, to recognize when they've received data that's governed by Part 2. Make a map of where Part 2 information originates, flows, and stops. Include both structured data like EHR fields and unstructured sources such as notes, faxes, and attachments. Implement labels or metadata flags within your EHR that identify a record as Part 2 sensitive. The more transparent your data landscape, the easier compliance becomes once enforcement begins. Identifying these records isn't about catching problems, it's about preventing them. The better your visibility, the more confidentiality you can support coordinated care while honoring the patient's trust. Now let's move on to the next slide, slide 10, internal workflows, what must change. Every policy change must translate into workflows and behavior change. Include Part 2 criteria and intake processes, release of information procedures, and EHR tagging. Ensure staff know when redisclosure is permitted and when it is not. Build audit mechanisms for tracking access and disclosures. And this slide transitions teams from awareness to action.
Let's map the flow here. Intake, care coordination, billing, HIM and ROI, and legal or documentation. Again, we kind of talked on the last slide about where the main questions. Where does Part 2 touch each step? Where do breakdowns occur? And what needs updating before February 16th? We're going to talk about another scenario here. A patient enters care through an integrated clinic. Let's start with intake. Where does Part 2 touch? The patient completes an updated notice of privacy practices and signs a general consent for a future TPO that includes SUD information. Where can a breakdown occur? Staff hand out the new notice of privacy practices, but maybe they document it in the wrong place. Perhaps the consent is scanned in, but not tagged as Part 2 content. What needs updating? the MPP and consent, including policies and procedures, a standardized intake script explaining the need for updated NPP and consent, and a single EHR location for the MPP acknowledgement and consent. And let's move on to care coordination. Again, using the same flowchart, where Part 2 touches. Care coordinators rely on consent status to determine that they can share with specialists, hospitals, or community partners. Where breakdowns can occur. Consent status is invisible across systems. Care coordinators assume HIPAA-covered environments mean everything is shareable. Mixed records aren't flagged, so SUD information gets embedded in general notes. What needs updating? Consent status flag or a banner in the EHR. A Part 2 decision tree. Is this Part 2? Do we have valid consent? Is this TPO? And maintaining documentation. I also want to add another pitch here for training on identifying embedded SUD references. Now let's talk about billing. Where Part 2 touches. Billing teams often handle encounter data that may include SUD diagnoses, program names, or service codes. Where can breakdowns occur? Billing files include SUD information that isn't properly tagged. Vendors can receive Part 2 data without an updated business associate agreement. What needs updating? Updating those BAAs that explicitly reference Part 2, a process suppressing or segmenting SUD-related codes when required. Let's quickly move on to HIM ROI. Where Part 2 touches. HIM verifies Part 2 status before releasing records and ensures that redisclosures stay in the scope of consent. Where breakdowns occur. HIM receives requests that look valid, but they aren't Part 2 compliant. Mixed records aren't labeled, so the entire chart is released. Or staff could rely on outdated ROI templates. What needs updating? A Part 2 decision tree embedded in the ROI workflow. Updated ROI templates that reflect the align rule. A tagging or labeling system for Part 2 records. And last, legal. Where Part 2 touches. Legal reviews subpoenas, court orders, and law enforcement requests to ensure that they meet Part 2's heightened security. Where breakdowns occur. Staff sends records to legal too late after responding to a subpoena. Legal receives incomplete information because Part 2 status wasn't identified upstream. And oftentimes, urgent requests create pressure to disclose without proper authority. What needs updating here? A clear escalation pathway. If it involves SUD, legal must review. A checklist for Part 2 complaint court orders, compliant court orders. A documentation trail showing verification, patient notice, and decision rationale.
When you map it out end to end, you can see that Part 2 touches every department and the breakdown happens in the handoffs. That's why updating these workflows is so critical for enterprise-wide compliance. Policy gives us the blueprint, but workflow is where compliance either succeeds or fails. Every privacy improvement depends on what people do in real time. Let's move on to slide 11, key takeaways. The final rule modernizes without compromising patient trust. It streamlines operations, enabling better whole person care. Compliance now calls for synchronized privacy programs across HIPAA and Part 2. Now is the time. Review, train, update, test, and validate policies and procedures.
The 2024 final rule represents a modern privacy framework for behavioral health, one that protects patients while enabling safer care coordination. It effectively closes a 40-year gap between how sensitive SUD data and the rest of a patient's health information are managed. After decades of operating in parallel universes, Part 2 and HIPAA are finally speaking the same language, the language of privacy. And that's a breakthrough for patients and providers. And while acknowledging that this may seem like an administrative burden, I want to emphasize the benefits. For patients, stronger rights, more transparent communication, and confidence that privacy remains intact. For providers, simpler operations, integrated compliance programs, and the ability to deliver whole person care without a compliance conflict. And for systems, interoperable electronic health records and smoother data exchange across treatment settings. This is not the loosening of standards, it's the re-engineering of privacy for the digital age. Protections still stand. No use of records against patients, and consent remains the key to disclosure beyond treatment payment healthcare operations. What's changed is efficiency, consistency, and alignment. Our job now is to move from awareness to action, to update those policies, to train our teams and test our systems, especially now that enforcement has begun. Remember, compliance isn't the finish line, it's the foundation of patient trust.
And the final rule supports the ultimate goal: better care, stronger privacy, and unified standards. Let's move on to slide 10, HHS and OCR resources. You visit the website listed here, www.hhs.gov/HIPAA/part-2 for resources including detailed regulatory text, model notice of privacy practices, and fact sheets. We encourage you to download and use the model MPP as a starting point for your organization's updated MPP. You can also find HHS's webinar on the website, recorded at the beginning of 2025. It features a very in-depth policy overview if you'd like to dive even deeper.
We encourage ongoing engagement. Regulations evolve and compliance is continuous. Stay tuned to OCR. They provide outstanding advice and guidance that will help your organization stay up to date on privacy and enforcement news.
We appreciate your time and engagement with today's webinar. North Country Communications is here as a partner to small and mid-sized organizations in strategic communications and healthcare compliance. You can reach us via telephone at our office at the number 518-290-1230 or the toll-free number 877-NORTH-20. And you can email us at info@northcountrycommunications.com with any questions. And if you haven't already, visit our website at northcountrycommunications.com.
In closing, this shift isn't just a regulatory requirement, it's a reaffirmation of why we're all here: to protect dignity, build trust, and deliver care that sees the whole person. These revisions remind us that privacy and progress aren't opposing forces. When we safeguard patient information and share it responsibly, we're building a culture of compliance that is both coordinated and compassionate. That alignment, patient trust, and true patient-centered care is where our work now leads. Thanks so much for joining me and Ryan today. We welcome questions, we offer free consultations, and we're here to help develop and deliver tailored Part 2 solutions and training sessions to organizations of any size. Thank you.
Thank you.